So as he mentioned, I'm going to be talking about articulating spacers, how they can be effective, efficient, and possibly everlasting. These are my disclosures. Haven't changed since this morning. Goals of the talk today, we're going to talk about how to set up the room for these types of cases and how to make an effective and efficient articulating spacer. So we utilize two setups for these cases at Ortho Carolina, basically a dirty side and a clean side that we're going to utilize in the operating room. The clean side is set up and covered. The dirty side is wheels out of the room during the room cleaning and re-prepping and draping. This protocol came out of our one-stage versus two-stage study, and it was part of that protocol, so we've continued that. So what all do you need? You can use any implant of choice for the femur, all polytibia or a total knee poly of your choosing, reamers, threaded K-wire tray, whole gauge, and cement with antibiotics. This is kind of what the setup will look like. So as far as antibiotic cement dosing, this is going to differ depending on what type of cement you use based on the elution properties. As you can see, it's a little different for Simplex versus Palicos. My personal preference is I like to use Palicos, a little more workable in your hands. But you use 2 grams of Vanc, 2.4 of Tobra per pack. Usually these cases on the knee side can get done with 2 packs of cement. So what goes on the debridement side, this is all your extraction tools, all your bony prep, basically preparing everything to trials, as well as irrigation solutions to include normal saline, hydrogen peroxide, and betadine. So optimizing exposure is an essential part of success in revision total knee arthroplasty. You need to be able to remove implants without risk to the bone stock in order to perform reconstruction. So like I said, the first step of this is implant removal. The second part is joint reconstruction. And one thing you have to realize, step 1 can certainly jeopardize step 2, so you need to be meticulous in your implant removal. So as you can see here, very meticulous, safe, expedient, bone preserving. All right, so let's talk about how we make an articulating spacer. This is kind of what your final construct is going to look like. How we do it, as I mentioned, we fashion dowels over a threaded K-wire. We unite this tibial K-wire to the polytibia. I usually ring the canals to about 13 or 14 millimeters, and I make sure the dowel can go through the whole gauge. So we start with brush-up cuts, both on our femur and our tibia. This is primarily used for debridement, so I'm just going to be taking a few millimeters of bone in order to debride that infectious material on those cut surfaces of the bone. Next, we're going to ream the canals, like I said, reaming to 13 or 14 millimeters, kind of up the river, down the river, doing this simultaneously with each reamer, and then kind of progressing up from there. Next thing we're going to do is I try to just place the trial utilizing the same 4-in-1 cuts from the original resection. Sometimes we do need to use the 4-in-1 block during this step to make sure the trials fit properly. It is okay to leave a little gap, distally. You can put on femoral augments with cement, and then that allows you to be a little more bone preserving. So once we've taken this to trials, at this point, we're basically going to whip stitch the wound closed. We're going to put Ioban over a towel, re-prep and drape, and then bring in the new clean side instruments in order to place the spacer. So our protocol is the same, whether or not we're doing a 1-stage versus 2-stage. It's basically whether or not you're putting final revision implants in or an articulating spacer. So the room setup, like I said, we clean it, we re-prep and drape. Some of that has progressed over time. Sometimes we utilize a double draping technique rather than a full re-prepping and draping. I do have some partners that do that. So on the clean side, we have the final impactors, K-wire tray, whole gauge, and all of our irrigant solutions. This is our irrigation protocol. The normal saline is followed by peroxide, normal saline again, and then betadine, followed by normal saline. This is done after resection and then prior to reimplantation of any parts. So as far as mixing the cement, you're using a lot of antibiotics in these cements, so it's important to go ahead and mix the cement on the front end before you've added antibiotics, as you can see here, and then just adding a little bit of cement as you go. Otherwise, that cement gets very chalky with the cement and the antibiotics in there. Next, we're going to unite the all-poly tibia to the K-wire. Once again, this is a threaded K-wire in order to bring the cement out with it when you come back for reimplantation. If you use a smooth K-wire, it's going to come right out of the cement, leave the cement behind. It's going to make for a little longer day in the operating room. So we do unite these as one construct. Next, we're going to fashion the dowels around these K-wires. This is on the tibial component here on the left side of the screen. And then we kind of just use the table to smooth this area off. Once that's done, I do check it with the hole gauge. You want to make sure that it goes through the hole for the size reamer that you use. Like I said, usually I use 13 to 14. Make sure it can go through that hole gauge. Next, we're going to fashion femoral augments. Like I mentioned, this is going to help balance out your gaps. You don't have to resect the bone right down to fit the implant exact. This allows you to bring that femur out a little bit and make up any space in your extension space that you may need while preserving bone. And so this is done, as you can see, with the left side, just adding augments with the cements from the first batch that I make the dowels with. Next, we're going to drill the tibia, put holes in the bottom of the tibia, and that's for added fixation. So we don't know how long these spacers are going to be in. Some people are going to retain these spacers, so we try to add a little bit more fixation with drilling holes in the bottom of this poly. Next, I always kind of do a trial run. I want to make sure that those dowels are going to fit into the bone. It's not going to be a good situation if you're trying to pound these in and they won't actually go in after you've already mixed cement. So I always kind of put these in on the front end before I put any cement on the articular surface, just to make sure they're going to fit. And then that leads us to the final cementation of the construct. We'll go ahead and place cement only on the articular surface. You don't want to put any down in the canal. You don't want to have to be getting that out when you come back for reimplantation. So as you can see, I do this by hand. And then we take our final construct here on the tibial side, and then we'll build up the cement from there. And we hyperflex the knee up. That allows us to add cement and place our femoral component. So here we can see that femoral component going on, hyperflex the knee up, you can clear the post. Usually I do utilize a PS implant for this, unless I've taken off a CR implant, in which case I may use a CR. And then we kind of put some cement buildup on the sides, both on the femur and the tibia, in order to increase our cement elution surface area. So articulating spacers can also be done in complex situations with more massive bone loss. This is someone who had an infected uni, actually, had a large tibial defect here. We went ahead and made our brush-up cuts and then built up that area with kind of a cement and screw construct, and then placed our articulating spacer, allowed the patient to fully weight bear on this during the spacer period. So the question is, do we retain or reimplant these patients? Oftentimes, this can be a long-lasting construct for these patients if done properly and done well in the operating room. This is a gentleman that I did who's about 87 years old. He came with a draining sinus laterally there. As you can see, we placed an articulating spacer. This is him walking down the hall with no pain. This gentleman actually would not let me reimplant him at his older stage of age. He wanted to retain the spacer in this case. So this concept of a destination spacer has become more and more popular. I think we mentioned it earlier today. These so-called 1.5 stage revisions or 1.5 revisions, where they're cemented into last. This study showed an 85% infection-free survival at 3 years. Obviously, it's cost-effective. You don't have to come back for reimplantation. Maybe. All right. And this is a study similar out of the Duke group, looking at this 1.5 stage exchange concept. Similar results, about 80% survival at 3 years. They said it was effective in the poor host. It's medically complex. But at the end of the day, they're essentially doing a one-stage exchange, and probably ought to call it that rather than a 1.5 stage. This is a study also looking at these retained antibiotic spacers out of the Mayo Clinic. Showed a little more dismal results than some of those other studies. They showed a 5% retention rate with 1,100 cases of PJI with spacer placement. Their all-cause revision rate was somewhere around 20 to 28%, but they did have a very high incidence of radiographic signs of failure when looked at these x-rays serially. So proceed with caution when trying to retain these spacers for definitive management. So our philosophy at Ortho Carolina, we actually try to reimplant everyone as part of our one-stage, two-stage study. And any patients we've done outside the study, we have a reimplant rate of about 99%. Otherwise, you're just doing a single stage in these patients, so you might as well call it that, rather than hedging with this 1.5 stage, doing a poorly done either reimplant or spacer and calling it a 1.5 stage exchange. You might as well just get good fixation, do a single stage, and the results have been shown to be just as good. I think this gives the patients the best outcome long term with these difficult problems that we face in arthroplasty. Thank you.
Great. Thank you, Keith. Next up, we have Dr. Kandemeyer, who's going to talk to us about intraoperative fractures around a total knee replacement. Thanks, Utku. Nice job.
Okay. So if you are doing enough number of this, that I think probably all of you guys that do at least 100 of the total knees, primary knees, you should have on average about 1%. Lombardi wrote a paper about 4.4%. It sounds a little too much in primaries especially. But looks like you will see some of this 1%. Again, this includes all kind of fractures. Doesn't mean there's an unstable fracture that you created, but you will see probably 1 or 2 a year, looks like it. Hopefully you are doing much better than that. As expected, because of the osteoporosis, females is more kind of predisposed to have this kind of a problem, including the size. PS knees, because you are taking more bone, also is an issue, and usually commonly is on the femoral side. When this happens, usually it happens during the impaction of the final implant. Unfortunately, like you are ready to go, you are ready to close, you are just putting your final implant there, then you start seeing something not right. Either it's get too loose, like you are impacting, it doesn't feel right, or you have some kind of a crack going on, or some of the condyles come off. Sometimes it happens during trialing, and sometimes during the preparation of the bone, because especially in a smaller size patients, mediolaterally, when you are taking a significant amount of the bone in the midline, and depending on the system you use. Also during exposure to, if there's a very stiff knee, either post-traumatic or for some reason very stiff knee where you're starting, and you start flexing the knee and you don't have enough soft tissue releases, then the force transfer to the bone, if the bone is soft enough, it may cause some avulsions of the bone. In the tibia, again, is most commonly during preparation for the keel itself, and it can happen, or when you impact your final component. There's usually some mismatch, what you prepare and what you put it in. What you are putting in is bigger than your preparation space. Obviously, it's kind of you want to make it as perfect as possible and as snug as possible, but sometimes it's not a great idea in a softer bone especially. Bone quality is the highest risk factor, obviously, because it's the crack in the bone. If there's the rate determining, kind of the main problem is osteoporosis, rheumatoid arthritis, advanced age. The older we get, our bone gets weaker. Female, chronic steroid use, and some kind of metabolic bone disease, one way or another. Is the medication-induced or some kind of genetic disease also. Obviously, PS implants, as I told you, the relative risk looks like about 5 times more. So it usually doesn't happen. This means that it doesn't happen in the CR knees, but it can happen 1 out of 5 times. Patient implant size mismatch. I think depending on the system you are using, especially in the PS knees, sometimes all the sizes have the same box in the middle because they use the same liners for the cam mechanism. So you are taking the same amount of the bone in a larger size femur versus a smaller size femur. Then the amount of the bone left after you cut your box cut, especially on the medial side, gets closer and closer. So this may be an issue. And if you start in a severe deformity and you are forcing the bone and everything a little more. In a PS knee, when you have a tight-fitting implant, right? So the space you created to put your trial or your final implant has to be a little wider to be on the safe side, especially the softer bone it is. If it is too snug and you are punting too much, with your mallet, probably you are transferring all the kind of forces to the condyles, and you may create a crack. Sometimes these cracks are like in the longitudinal cracks. It also happens when you are trying to take out your trial out, or you are putting your implant back in, a little more varus or valgus relative to your cuts in the PS knee. So then you are forcing again towards creating a fracture. And the distance, because of the anatomy, medial side has less bone. That's why most of this medial condyle fracture happens on the medial side, which is a bad problem, obviously, because the medial side is more important. What are our goals? Obviously, you don't want to change. A patient comes in for an elective surgery. They expect that they're going to start putting weight on it right away. They're going to get rid of the crutches in the next couple of weeks. You don't want to change that post-op protocol if possible, because it's kind of a big disappointment that you need to explain to the patient too. And obviously, whatever you put it in there, hopefully it doesn't change the longevity of your implant. Like, it doesn't get loose sooner. Obviously, it's not going to get loose in a month or two, but you want to still keep that 15, 20 years longevity, the survival of your implants too. I think you got to follow the principles of both arthroplasty and the fracture. When there's a fracture, you got to make it stable, kind of the fracture needs to stay stable that can heal. And for the arthroplasty, if you have an unstable fracture site that's not completely stable after fixation, or for whatever reason you don't feel comfortable, your post-op rehab, you're going to do weight bearing or touchdown, you need to be ready to use some kind of stamped implant to bypass that fracture. The real question comes in when you have a fracture. Depends on what type of fracture you have. Can you weight bear, or should you do some partial weight bearing or toe touch weight bearing postoperatively? This wasn't the goal to begin with, but now you got to make some kind of decision, thinking about the patient, what is the best. And do they need a bracing, especially if there's a medial epicondyle avulsion type of things? I think in coronal plane, the bracing may help to avoid further stresses until the fracture heals. So most of the fractures are non-displaced on the medial and lateral condyle, and actually just putting screws, if they're not complete and not unstable, meaning that if you cannot move the condyle visually, you cannot see any motion in the condyle, you see just the crack, I think just putting the screws will be fine. And there's a good literature about Auto Limited that they usually do fine. If it is displaced or the condyle is unstable, obviously you got to do something more, because you're going to impact a component on it. You want to let the patient weight bear. You don't want this thing slowly sink in varus or valgus, depending on which condyle you have. Ideally, you want to do some kind of buttress plating. So that's what, as a fracture surgeon, that's what I will tell you. Again, it may require a little more exposure and calling another set and waiting another 5-10 minutes from your SPD to get that bad. But it's probably safer bet to avoid any major problem down in the line. If it's just the epicondyle, which seems to be actually less common per the literature, although I think I hear more about these epicondyle fractures more. Nobody seems to want to be very famous in the arthroplasty world about these fractures. There's not much written. Actually, I just checked last couple of days. It's still limited amount of information. I think it happens, but usually it doesn't happen a big deal, and nobody wants to write a big series about it. So this is a patient with an intramedial condyle fracture, as you can see here, with aseptic loosening. And if you have this medial condyle fracture, then you cannot really go and put your implants in there and expect that you're going to let the patient weight bear, because it's a half of the whole distal femur. So you cannot use the regular. This was during a revision case, obviously. Then we ended up putting a plate in there. So we use a kind of at that point, we did not have any specific medial plates. Doesn't have to be. On the medial side, it's very hard to fit any plate, but a buttress plating, as you can see what we did, also bypassed. This was a revision. This was a planned stamped component anyway, but still, you don't want to compromise the longevity of your component. And this is the 6-month follow-up for that patient. Tibial fractures, again, if there's a vertical fracture line, like cracks that doesn't go down, you can just use the compression screws, unless it keeps splitting when you are putting your final implants. When you have a plateau fracture that you see on this picture on the very end, if you can just bypass with your stem, because on the tibial side, the shape of your tray actually doesn't help with your stability, right? It's not like on the femoral side. The rest of the implant and the other connections on the sagittal plane have some stability. On the tibial side, it just comes from the keel, and if the fractures are around the keel area, I think the best way to just get a longer stem, and you may need to put some screws around it. If there's a metadiaphyseal fracture, you definitely need to go longer, and you may need to put a plate. This was a two-stage revision patient for infection, and a TTO has been kind of done for the revision of this patient, and everything went okay during the TTO, but after the couple of weeks on the follow-up, about I think 5 or 6 weeks after the follow-up, the patient presents with increased pain and not being able to put weight on it. Obviously, the TTO ended up completing distally, and we ended up fixing this with bilateral, bicolumnar fixation, because the fixation was, I mean, the proximal part, metadiaphyseal zone 1 and 2 was completely fixed. We aimed to fix the fracture like this. And sometimes you find out in the post-op x-rays, and you find out that things may get kind of different. And so everything went well. Then post-op x-rays in PACU, and you obviously don't do your x-rays in the OR for efficiency reasons, that because usually not necessary. These are one of the 100 or 200 of the times you may see something different. Again, everything went well, and the patient's post-op x-rays and the PACU, you look at it and there's a crack in there. And what to do? Obviously, during the surgery, there was nothing unusual. There's nothing unstable per se. And post-op x-ray doesn't look like any of your components unstable. Then we had with this patient, both the arthroplasty surgeon and the trauma surgeon got a discussion with the patient what to do. I think you can try to go both ways. My personal recommendation was to fix it, that not to have a nightmare about this thing. It may work, just toe touch, weight bearing, etc. But I felt that it will be much stable and safer to just fix it and let the patient do weight bear. So that's what has been done for this patient, to be on the safe side. And the patient chose to go that way too. Take-home messages. I think you got to be beware of high-risk patients, that you got to be more careful when you are using your implants and your mallet and you are putting your implants or final implants, etc. You should not ignore the subtle signs in TROP. If something doesn't look right, then don't bury your head under the sand. You got to check your PACU x-rays. Again, the x-ray that I showed you, it was a PACU x-ray as usual. If you don't check it and you find out the next day or a couple days later or a week later, probably it's not going to be fun to explain to the patient, and also may go much worse with the patient weight bearing. For unstable fracture, you got to think about can affect the weight bearing or not, and you got to need to do some stable fixation and as needed stamped components. Thank you.
Thank you to Uku. Stefano is going to come talk to Stefano Bini is going to come up and talk to us about the patella and total knee arthroplasty.
Thanks, Tom. Great talks from the previous speakers. I fell a little bit in love with this topic. I hope you bear with me. I may go a minute over. But I do think the patellofemoral joint is kind of the last frontier in arthroplasty. Tom will pull me back. This is the series of lectures that's going to talk about a short history of the human knee. I think you'll find that interesting. The impact of alignment choice on patellofemoral trochlear alignment. I think that's a hot topic. Design considerations in TK based on what we learned. Talk a little bit about the trochlear offset and the clinical impact of trochlear mismatch, and then a quick review of the registry data. So what you may not know is a patellofemoral joint evolved separately from the knee joint. So 300 million years ago in the Paleozoic area, the tetrapods, the medial condyle articulated with the femur, and the lateral condyle articulated with the fibula. So it wasn't until about 70 million years ago when the fibula of proto-mammals shortened considerably, and then both condyles shifted to articulating with the tibia. They did not develop simultaneously. That's why those two do not work well, and still we don't have a patella in the picture. That happened 70 million years ago when the very first patellas appeared in mammals, and then only in the plantigrades, not in the ungulates. Actually, take it back. Both had patella, but they look very different. Because in ungulates, kind of deer, the knee never fully extends, and the patellofemoral joint and the trochlea and condyles remain distinct. It wasn't until we became plantigrade that the trochlea became contiguous to the condyles and flat. Right? So these three joints came together over time, so it should be no surprise that, in fact, they have different bioanatomy, biomechanical properties. So in hominids, that's when we first get the knee that you and I know today. That was about 4 million years ago. You start getting a valgus orientation of the femur, you start getting germline obliquity, you start getting extension and anteriorization of the lateral femoral facet, right? That big bump on the side there that wasn't there before, is all flat, and lateralization and flattening of the trochlea. So these behave independently as a result of this. And yet, despite this variation and this history, because we're not aware of it, the implants bundle all these into one average alignment. And this should be no surprise that they don't always work. So the trochlea and patella have variable geometries. The tilt, the angle, the depth of the trochlea varies from human to human. The patella has a different axis of rotation entirely from the tibiofemoral joint. It can also be argued from a biomechanical perspective that it actually doesn't have a true axis of rotation by the way it works. So this extensive variation in trochlea tilt, the trochlear angle, the depth of the sulcus, the shape and size of the patella itself, the presence of osteophytes, and the way the patella tendon interfaces with all this leads to variations in anatomy that cannot be answered with a single implant. And then there are some results of this. So let's look at mechanical and then kinematic alignment and how they impact this variation we just learned about. So when you do measure resection largely off the medial femoral condyle, it's not unusual to have a miss or a very small resection laterally. We used to call that a hypoplastic lateral femur, and I showed you last conference here that there's no such thing. All femoral condyles are created equal, the lateral being slightly larger in all humans, but just by changing the angle from the native 9 to 6, you're going to miss the lateral femoral condyle. What that does is you're going to put metal distally to what's called the lateral column. It's a concept that's now been popularized in Europe, and that tends to prosthetic overstuffing, tightening of the lateral retinaculum, and leading to patellofemoral tilt, and often lateral releases in this construct because we've created it. With kinematic alignment, we have a different problem. We restore the columns accurately, but the implants aren't designed for what is a 9-degree takeoff angle on average. And so what you're having is that, one more thing, the femoral component when you do K, especially if you do it with a robot, tends to be more flexed, which brings the trochlea distal, and then you have problems with leg capture, and you have problems with inaccurate alignment between the angle of the pull of the femur, the patella, and the trochlea. In terms of implants, another problem we have is that if you look on the diagram on the left, it shows you a line on top, the gray one, which is a native anatomy. Implants tend to have a lower, deeper anatomy than native, so you're actually losing anterior offset, and you can see by how much on the graphs on the right. Furthermore, if you were to try to optimally design features for a KA-friendly, in other words, a more anatomic knee, to adjust for all human variation, you'd have to have a patella takeoff angle, which is plus or minus 6 millimeters from where it is today. Much, much wider, but then you capture 95% of the population. And similarly, the deviation of the sulcus would have to be plus minus from 7 degrees basically to 19 degrees, and if so, you get to 95% of the population. You can see it to the right. It seems like big numbers, but in reality, we have plenty of real estate on the distal femur to create a trochlea that allows us to match the wide variety of variation in human anatomy. So enter the age of robots and preoperative CT scans and all kinds of ways to look at these interfaces preoperatively. And what we see that, I'm going to show you 3 papers, all of which looked at the interface of the implants and the trochlea based on how you align the components. And what this one showed, and so many others at the same time, is that essentially they all increase the trochlear angle varus. They all shift the sulcus laterally from anatomical. They all understuff the trochlear groove, and they all translate the sulcus lateral extension, but medially in flexion. This is sort of representation. You see at the top here in the second image that the green, which is the implant, is superior to the trochlea at that specific anatomic point. So mechanical alignment across the board has outliers, but KA and FA also have up to 50% outliers, and outliers being more than 3 millimeters or 3 degrees off the axis of the native knee. So what we're doing isn't reproducing the native trochlea, and therefore, no surprise, patella tracking is a problem, regardless of how you choose to do your knee replacement. There's another article looking at exactly the same topic, looking at understuffing. But now we're starting to look at clinical impact. And what they show was that understuffing did not impact PROMs, but overstuffing definitely did. So perhaps we should start looking at being a little more careful about our patellar resections and also about restoring the trochlear height. There's another paper looking at exactly the same topic and understuffing at various angles of flexion and finding that in flexion, overstuffing at 90 degrees or more really is where you start to get more of the problem. But then that raises the question, where do you measure the stuffing from? Specifically, on the trochlea, we have is a surface which is a surface native or is it an osteophyte? We see this in the acetabulum. This is a medial osteophyte. Some people ream right through it to the medial wall and to the teardrop. Others leave the cup lateralized to not lose the offset. In the knee, it looks like this. On the right side, here's an osteophyte, but there's a patella tracking on it. If you remove that osteophyte, are you releasing the offset? And if so, are you weakening the knee? And if so, is that one of the reasons your particular patient is having some problems with anterior knee pain? So these are two variations. These are two patients. They don't belong to that X-ray above, but just for illustrative purposes, which knee is the correct knee? They're both from our hospital, two different surgeons. So in terms of revising knees for patellofemoral pain, it's still not a particularly big number. If you look at this AJR data, not the best data in the world for this kind of thing, but still less than 1%. So it's interesting. Now, the other question is the patella itself, and the patella and the patella prosthesis. We tend to just assume they're all created equal. But in reality, the modified dome is far more adaptable, but has higher contact stresses because it's less conforming. Whereas the anatomic one, which has lower contact stresses and more conforming, is super sensitive to malalignment. So if you use one of these anatomic patellas, but you're looking at the fact that 60% will be malaligned, you're going to have trouble with polywear. And overstuffing can happen with minor changes in the native trochlea versus the patella trochlea. What you see here is a line, the little dotted line is where the original patella would have been, and that plastic is the part that's overstuffed in the space. Now, another point of reference we saw before discussing the American registry and the Australian registry and sort of comparing them. This is what's happening in Australia. They're moving away from unresurfaced patellas in a big way, which is surprising. I have no idea why. Whereas in the United States, we're actually slowly edging towards more resurfacings, fewer resurfacings. Yet the revision rates based on resurfacing are essentially no different between resurfaced and unresurfaced. And what you see is unresurfaced or surface above. But again, this is not statistically significant, this particular variance. So the patellofemoral joint is distinct from the tibiofemoral joint I showed you earlier. Some people say that patellofemoral issues are as high as 20%, 7% in the Australian registry. I think that's a little bit overblown, but I think it's still the last of the questions. Now, keep in mind that the patellofemoral joint, I think the story has still to be finished. Every time we close a medial retinaculum after an arthrotomy, we're literally tightening the medial side. There's no way you can restore that closure without some amount of shortening of that ligament. And it's super sensitive to tightening. We know that. So there's going to be something. We're going to learn something about that. The fat pad has a massive impact on patellofemoral kinematics and impacts it post-op if you resect it because it's going to scar and shorten if you remove that bumper between the tendon and the joint. We haven't ever talked too much about joint tibial phenotypes, but there were papers back about 6 years ago in the journal, about 3 in a row, showing that internal tibial rotation was more associated, had a very strong association with anterior knee pain. External rotation, any amount of external rotation had no impact on anterior knee pain. That sort of went by the wayside, nobody paid attention. And then the tricompartmental union. We just showed you that each of these compartments behaves anatomically differently. And people have been talking about whether we should be doing each compartment separately. And there's a question mark for that. And then the osteophyte. All right, Tom, I'm sorry. I went a little over.
It's okay.
Thank you.
Thank you. Great talk.
And come to the conference.
All right, Derek Ward's going to talk to us a little bit about the reproducible revision total knee workflow. Thank you, Derek.
All right. So we could also just advocate for universal patelectomy. No kinematics involved. All right, so I'm going to talk a little bit about revision total knee and how I kind of approach a revision total knee. These are my disclosures. They are not relevant to this particular talk. I'm going to go through exposure, implant extraction, reconstruction. I've tried to sort of simplify some of this as much as possible to give people some principles, but obviously it's much more complex. But I really like talking about this topic because this is actually my favorite surgery to do. And so if I could do one surgery the rest of my life, this would be it. It would be revision knees. So skin exposure, standard principles are you want to utilize prior incisions where possible, but prioritize the lateral incision. This depends a little bit on sort of how lateral it is versus how medial something is. If you really can't use the lateral incision, then you want to leave at least a 4-centimeter skin bridge. If you're going to cross prior incisions, you want to cross them at wide angles. So you may make a really funky shaped incision in order to cross another incision at a different angle, but that's better for the blood supply. And then you want to make a large incision, not just because of the exposure aspect of the revision, but also because this puts a lot less stress on the skin edges at the distal and proximal end. And that, I think, leads to a improved wound healing if there's less sort of tug on the skin. I don't excise the skin edges until the closure, until I make sure that I can really close the knee well and there's very little tension on it. And you want to keep the fat with the skin because that's where the blood supply is. I also have a fairly low threshold to involve my plastic surgery colleagues at the outset if I think there's going to be a real problem with the incisions, because I think it's better to do the plastic surgery part of it prophylactically if you need to. So if there are weird, funky incisions or a skin graft that's adherent to the medial tibia or something like that, it's better to do the flap when you do the revision than to wait for the skin to break down and then have to deal with the infection. So this is a wordy slide, but this is sort of my approach to exposure. Essentially, exposure for a revision knee is kind of like the opposite of exposure for a primary knee. I work from extension to flexion. I work from anterior to posterior, and work from the femur to the tibia. So I do a big incision. I love big incisions. A very generous arthrotomy. I'll then expose the anterior femur in extension, remove as much scar tissue, do a fairly thorough synovectomy, especially if it's infection. Then I'll release the lateral gutters in extension, start the medial release in extension, and remove as much scar behind the patella as I can in extension. Then basically I'll start flexing the knee and see where I get, and that will then trigger a series of different decisions as to what I need to do. In terms of where you're at, and then how much you can sublux your patella. So that'll then go to a larger arthrotomy. If I still can't sublux it enough, I'll do a quad snip. And if it's just very clear at that point where I'm only getting minimal amount of flexion, 30, 40 degrees of flexion with all of the soft tissue releases that I can do, then I'll progress to a TTO, although most of the time you can predict if you're going to need a TTO ahead of time. Then as I continue to progress through flexion, I'll start to sort of release the rest of the gutters that I kind of can't see in extension, do any sort of anterior and distal femoral tissue release, continue the medial release around the back of the tibia. And people always get really nervous about sort of how much stress you're putting on the patellar tendon. However, with the patella subluxed, flexion is actually protecting your extensor mechanism. So you can be a lot more aggressive about your flexion as long as your patella is subluxed, because there's less tension on the patellar tendon. Then take out the liner, remove the femur, then sublux the tibia and expose and finish your medial release, and then remove the tibia. And that's kind of my workflow for exposure. So implant removal is not just hitting it harder. This is not hammer time. God, that was such a good video. Implant removal is all about patience. So I think that, we're all excited to get to the exposure. These are long surgeries, but you can really burn some bridges and kind of burn yourself if you don't have patience on your implant removal. So I'll start with a very small saw blade, go around the edges of the implant, use some thin flexible osteotomes. I'll use footed or shaped osteotomes for some of the edges of the implant that you can't get to with a straight osteotome, a bunch of regular osteotomes in sort of different sizes and directions. And then there are some specialized extraction devices. Some of these are implant specific, some are implant agnostic. but those can be really helpful. Sometimes you can stack osteotomes, and that can be very useful. Using these kind of, these shaped osteotomes I found to be quite helpful. And then with sort of bigger implants, there are some universal extraction devices which can help you get a more axial force on the femur or the tibia because every time you use a bone tamp, you're sort of tilting into flexion or extension or varus or valgus, and sometimes it can be difficult. I've found these specialized extraction devices to be much more helpful in removing revision implants than removing primary implants. I don't think they're really necessary in primary implants. So just for discussion of exposure and some pictures, this was a recent case of what I call extreme polywear. This patient was relatively stiff, but with sort of a series of releases, we were able to get good exposure. And so these are, I think there's a couple releases that are really important, because the hard part is always the tibia, right? So a couple releases that are really helpful for the tibia. One is this sort of, distal medial soft tissue release. So I'm being very respectful of the MCL and where that is, but I'm willing to release a lot of this tissue off the anterior tibia pretty distal to the implant. That's 6 or 7 centimeters distal to the tibial tray. And that can really sort of help your tibia sublux forward. One of the principles I learned from Jeff was go far to go near, so go distal to get released proximal. So if you have something tight, you want to release distally, and then often the proximal stuff will open up. And then if you sort of get this, some kind of 45-degree retractor posterior to the tibia, and then you can really push it forward, continue to release around the back. You're sort of working both proximal and distal to kind of the MCL, and then that really allows you to sublux your tibia forward, sublux your patella, and then you can get this kind of shot over the lateral side of the tibial tray and right across the back of the tibia, and then you can get to all that posterior lateral area of the tibia that's most difficult, where you tend to get more of your bone loss. And you can get kind of down the back part of the keel of the tibia to kind of release there, so you don't pull out a big chunk of your posterior tibia with it. And usually with this kind of exposure, you can generally get the tibia out with a minimum of bone loss. Other tricks for implant removal when you have bigger implants. So for long cement mantle, I think using the UltraDrive is really, really helpful. A burr and a lot of patience. I also think that C-arm is a pretty helpful adjunct when you have these big cement mantles, because what you can do sometimes is you have a radiolucent table, you get a C-arm in, you take a drill, and then you can use sort of live fluoro to bypass your cement mantle with a drill without going out the cortex, and that can really be helpful to then get your UltraDrive in to get the rest of the cement to kind of back out. One of the advantages for me of using sleeves is that sleeves can often be removed without osteotomies, and I'll show that in the next couple slides. Cones, unfortunately, if they're well done, I think cones almost always require an osteotomy to get out safely. On the femur, this is sort of a relatively aggressive anterior bone window for me, so that I can work around the augment and kind of get the tools sort of proximal to distal behind it. And for the tibia, it's a TTO. But even with those osteotomies, these well-fixed cones can be quite difficult to remove. So this is how you remove a sleeve. This is I had some pictures from this, but these were the ones from Doug Dennis's article were a little bit better. So you don't actually have to burr the bolt away with a metal cutting burr on the femur. It's a Morris taper, so as long as you're diligent about removing the cement mantle behind the femur, and then you can actually just disengage the Morris taper and get the thing out there without actually having to burr away the bolt. But if you're a little bit scared about that, or it's just not coming out, then you can use a metal cutting burr and sort of burr away the bolt. Now with the Attune revision system, it doesn't have a bolt, so you just have to disengage the Morris taper, but I haven't found that to be too much of a problem. Then you can work with a burr and flexible osteotomes around the sleeve, and as long as you're patient, you can usually use a back slap, and they have ones that screw into it, or you can even get a vice grip which screws into a back slap, and you can get the thing out without too much bone loss. And then I'll show what I sort of do in the tibia. So this is a case of a lady who had well-fixed sleeves, but she was unfortunately infected, and we were going to do a 2-stage on her. And so we were able to knock off the femur and get the femoral component out just like you saw on the previous slides. And then with the tibia, you can see that the distal part of the tibial stem is much bigger than the sleeve. And so it's not going to come out through the sleeve. But what you can do is you can disengage the Morse taper, and you have about 2.5 or 3 centimeters of Morse taper to pop up. So you can pop the tibia up, you can spin it around, and then use like a pencil tip burr and thin flexible osteotomes to get around the entire part of the sleeve. And then there's a little screw and extractor device that you can just use to sort of backslap the rest of it out. And that's Dr. McDonald taking it out. And again, if you're patient, you can take these things out with a relatively little bone loss, and you leave some, pretty good cavities to reconstruct. So when we went back to reconstruct her after her spacer, we were able to just put in like 1 or 2 size bigger sleeves because we had preserved that bone. So. It's one of the reasons I like using sleeves is that they're easier to get out if I ever have to get them out. So these are my basic principles for reconstruction, trying to sort of simplify it down to how I work through this flow. So I start with my extension gap. I'll recut as a little bit to achieve extension, but I try to minimize the femur recut to not raise the joint line. When you're looking at your extension gap, you have to remember that you don't have posterior condyles in when you have that empty bone space. So you need to account for that because it'll tent your posterior capsule. So you need to add a couple millimeters to that. Then I'll go and look at my flexion gap, and that's usually my decision point for constraint. And what I mean by that is if there's a wildly different flexion gap than my extension gap, then I'm actually going to be starting to think about a hinge versus something that's semi-constrained. Then I'll prep the tibia. I'll use something to raise my tibia or lower my tibia as I need to, either a recut in the tibia or use a thick tibial tray to raise my tibia. You can also use sleeves and cones to raise your tibia. And then I'll prep the femur. With the femur, it's largely about closing down the flexion gap. So I will upsize my implant, increase my offset, or flex my component down to close down my flexion gap. And that usually will help you with your balance in general. So these are just sort of broad principles about how I'm looking at this and the order in which I look at them. So managing bone loss, I think cones and sleeves have become the mainstay for this. They both work great. I think stems are fine. Short or long is okay. I'll consider longer stems for uncontained defects. I almost never use augments anymore in the era of cones and sleeves. I just don't think that they're that useful. Although I will use them if the implant company doesn't have a thick tibial tray. You can put augments on both sides of the tibia to just make it into a thick tibial tray. And I really think in this day and age, you should be looking for a reason not to use a cone on or a sleeve, especially on the tibia. I think on the femur, it's a little bit more dealer's choice, but on the tibia, I think that you're really going to lower your re-revision rate by doing this. And then sleeves versus cones, they're both great. I think there's some particular instances where one works better than another. So I think sleeves in my mind, they just work better on the femur because they're the shape of the femur and they don't direct your stem. So a cone for me, in anyone who's not really big, will just direct my stem in one direction or another on the femur. And it becomes very, very hard for me to sort of put the femur exactly where I want it with a cone, especially in a smaller person. Not always, but I found this is where I found the sleeves to be really helpful. However, the sleeves really don't work on an uncontained medial defect on the tibia. There's just too much varus stress on it, and that's where they're going to fail. So just to go through some brief cases, just to show some things. Dr. Cantemir showed this case where he helped me fix this fracture. But this was a really big guy, and so with his aseptic leucinin, I couldn't get a sleeve to get stability on the tibia, so that's the largest cone, and then I put augments on the tibia to raise the tibia up, and then distalize his joint line with some augments in the sleeve, and did this sort of hybrid fixation. And that's the fracture that Dr. Cantemir helped me fix. So, yeah. Okay, all right. Here's just one where we didn't have to put augments on the femur. And then this is the last one I'll show, which shows massive bone loss in the tibia, where you can actually stack cones to recreate the tibial joint line. And that patient does really well. All right.
Thank you. It's wonderful that we have everybody that's so excited about speaking up here, but we ran over rather considerably. So, Jeff, do you want to ask questions here, or you want to just go right to the next session?
Or two.
Anybody have a question or two to the group?
Hi, Craig Hogan. Keith, I know that you said at your shop you're replanting everybody, but for us out here, I mean, I find it hard, when Carlos is talking about the 1.5 stage and we all do it, but what do you recommend for us and for people in the audience? Like, should you be trying to make that decision preoperatively with the patient? Or like, hey, we're going to try to do one, your spacer's staying in for life, or what do you guys, what are your recommendations?
Yeah, I think it's always better to have that conversation with the patient on the front end if you're thinking that maybe they're not medically fit to have 2 surgeries. I think it's prudent to talk with the patient about that early on. I mean, I said that we pretty much reimplant everyone, and I kind of talked to them about that on the front end. And the day that we resect and place a spacer, I basically send my surgery scheduler a save the date card and basically get a date for that person to have their reimplant a little more than 3 months out, just so we have it out there. Now, some things may happen, they may get pushed off, may get canceled, but we at least have it out there with the plan that we're going to be reimplanting them.
Yeah, sorry. Just one other question that came to mind on that, because I think none of us really know when the ideal time to replant is. We don't have good guidance, all of that. But if I'm not mistaken, I think there is literature out there that suggests that these destination spacers, like if we keep them in, it's old literature, but like the ideal time to go back in is between that 3 and 6 month mark, right? So you have someone that has a destination spacer and then 2.5 years later it fails. Are you doing a 2-stage on that, or
No, I'm going to.
it depends on the workup.
Check markers,
Yeah.
aspirate them preoperatively. If that all checks out okay, I'd feel comfortable reimplanting them at that time.
I have a question for Stefano. Stefano, as you know, evaluating the anterior knee pain is very complex. We have very poor tools to do so. And when we look at the way we prepare the patella, the variability is so big, whether you use a patellar saw blade, a reamer from Smith & Nephew, you recut it. The question is, do we have any guidance to choose between sizes whenever you're between 29, 32, or 35? Do we have actual data to say that for this particular size of femoral component, if I'm between sizes, it's better to use a 32 or 35?
No. However, the width of the patella, what I just showed you, you should be less worried about the size of the component than the height. For some implants, you go from 39 to 41. It's actually a 3 millimeter augment. So it's more about how, taking into account the size. So I'm crazy neurotic about this. I have no idea if my results are any better. But you know the nose of the patella, it's called the apex? That is always, always, always lined up with the ridge of the patella. So if you've lost bone there and you can't tell where the ridge was, you just figure out the feel for the nose. That should be where your button should be centered. Don't over-medialize, over-lateralize, put it back where it was, and then make sure the height is where it's at. And that's, so I measure the height, before and after, and if you got bone loss, you're gonna have to guess, and 26 is about average.
Okay. Thank you all.